Maybe it's not practical. It's not practical. That's why we try to do some slow marker to reflect. At least as we know that engine level quite correlate with the cccDNA in E positive patient, but not in E negative patient. So I don't think it's practical to treat the patient and monitor cccDNA in the liver tissue. I think we can. In the future, we look on the silo marker with associated with a good long-term outcome. That might fair enough. Even you cannot clear cccDNA absolutely, but you're able to significantly improve survival and significantly reduce liver disease complication. I think that's fair enough.
I think practically, you know, theoretically it can be true, but practically I don't think that's going to be the problem, because if you got an acute hepatitis B patient who is fully recovered from acute hepatitis, got S negative antibody to surface antigen positive, still they got to be cccDNA in the liver. So I think the best possible outcome for the treatment, I would say, just to make it S0 conversion. And if you want to test at the total absence of cccDNA, that means you've got to take the whole liver out to test it.
Questions? Kid?
Professor Dawisek, what is your opinion about the role of pegylated interferon at the current scenario where all the DAs are available? There's no rule at all, or do they still have some rule?
I think, as I've told that, for genotype 2 and 3, 2 is, I think 2 is, since SORB is very potent, so there's no role. But genotype 3, especially for those who fail previous DA, most of them will have RAF persistent. And at this time, you don't have any drug available, and PEG and RIBO are still sensitive to for the treatment. And for naive, I think it depends on the cost. So if the cost for DAA is much cheaper, and even cheaper than PEG RIBO, who go for PEG. But still, for those who fail DAA, I think until you have new drug available, or you're going to use it at a longer period of time, so those who persistent RAF, I think PEG and RIBO may be effective in this population.
Any queries, comments from the audience? If not, Professor Umutwe.
Thank you. For B, would like to ask one question. If the patient is responding with the nucleotides, then I've got some patients who have a persistent E antigen. So in that case, although sometimes the viral load may come down, but it goes up. So how do we sort of approach a patient with persistent E?
I think that's a really good question, particularly in this part of the world where we still deal with E positive patient. This Western world, they don't see much E positive now. And I same explain that we see some, those who have DNA suppression for more than 4 or 5 years but remain E positive. When you look at the all registration trial, including even lamivudine, anti-anticoagulant, tenofovir, you can see that usually in E positive patient, you see E0 conversion significantly high only the first 2 years. You can see that first 2 years can have 20%, 30% higher than placebo group. But they never compare after 2 years, 3 years. But you look on the cumulative E0 conversion, you will see that it will become flatter. It always 20, 30, 40, and remain really almost stable. This is a very common phenomenon. For myself, I believe that to achieve serological response, you require part of host immune response. At the beginning, for the first 2 years, when you suppress DNA, you restore T lymphocyte function. And that's why even antiviral agent, you can see 15% develop ALT flare. So among those who have an immune response, they clear seroconversion. After 3 years, now when DNA become undetectable, you put the patient in another balanced state, the state that no longer trigger host immune response and require only antiviral agent to suppress DNA suppression to undetectable. It have a good long-term outcome, as we know that it reduce the risk of cirrhosis and reduce the risk of disease progression, but they remain positive. That in this patient, from our own report a few years ago, we know that those who remain E positive after 4 years is quite unlikely to achieve E seroconversion. That's same as Trinity. So it depends on if your patient has so good compliance and they not complain about taking long-term antiviral, just put them on until long-term. This can be maybe 10 years or potentially lifelong. But if they complain and they begin to have poor compliance, you might look at the Chinese study or SST study. You switch, because that study look at those who are on anticoagulants at least 9 to 36 months and have DNA suppression but remain E positive or low E antigen level. They switch to PEG interferon. And what you can see from that study, you can see they have higher E seroconversion. But more importantly, I will look at the surface antigen level to pick up the right time to switch. If you look at the antigen level, if it's below 1500, it's good time to switch, because among those, about almost 20% also have SLO. So you have two strategies. Discuss with your patient. If they're happy with antiviral agent, this is continue. And lastly, if they have low E antigen level, you might follow Thomas Burke, that but in negative patient, if they have no cirrhosis, no advanced fibrosis, they have DNA suppression for 4 or 5 years, you might be able to stop. And we know that when you stop, the rising of DNA can trigger host immune response as well. And after that flare, some patients achieve E seroconversion. And from Thomas Burke study, they found that those who stop and have rising in DNA, they have significantly further decline estrogen, and some of them even achieve SLO. So you have 3 strategies together. Discuss with your patient and look at their condition of underlying liver disease.
Thank you very much, both speakers. And I would like one last question.
The patient was E antigen negative, and initially his DNA load was moderately high, but without any treatment, after 4 or 5 years, the DNA level has come down to undetected level. Initially, the liver enzymes were also normal, and now there were no symptoms, and it automatically came down to a normal level. Is there any risk of complications in that kind of patient, and would they need any treatment if the DNA comes down automatically to undetected level?
Okay, that is one of the good questions. As we know from the natural history, when the patient, even they start with the E antigen positive, but over time, due to host immune response, they become E negative and lower DNA over time. Okay, and they can come to the we call immune control phase. But if they still have E antigen high, no E antigen negative but DNA high, that means they go to the 4th phase already. They have reactivation with mutant virus. Again, you're right. You look at the E negative high DNA. 44% have normal ALT with intermittent flare. Another 36% have minimal elevated. And another 19% have minimal elevated with intermittent flare. That means it still have ongoing some asymptomatic liver disease in the body. Okay? And if you live one day, they may become to DNA undetectable, as you say, even without treatment. But the main problem is, the longer you allow this process occur in your patient, you put them on the list of more significant liver disease, and also they remain the list of liver cancer because it's already have incorrect in the patient genome. So that's why it depends on the time. If this thing happened before 40, the list of liver complications will be quite minimal. But if this thing going on until after 50 years old, even that time, they have no DNA detectable, but you can see the risk of liver disease still occur. This beautiful study reported from Hong Kong. They look at those who even have S seroconversion spontaneously. After age of 50, the risk of SCC still remain higher than general population. So what I'm going to do for you, if they come to the undetectable already and know I have to assess liver disease, if they have cirrhosis, I will still give them antiviral agent. If they have no cirrhosis, only minimal fibrosis, I just monitor and follow up and say that you might have the risk of disease but lower than those who have higher DNA and still require some time SCC surveillance if they older than 50 years old. And last thing you can discuss with your patient, even patient acquired perinatally in our region, you can see only 45% die from liver-related mortality. Another 55% did not die from liver disease. They can live with hepatitis B like your patient you just mentioned. So the best way in the future, we have to identify the host and viral factor to identify those who are not going to have the risk of liver disease, and that maybe you not require treatment, but require monitoring.
Say one more question to Dr. T for the B. I have seen some cases of the PEG interferon therapy for 1 year. To some patients, we are following the patients and we do the quantitative HbS antigen level. At the end of the treatment or months after treatment, quantitative HbS antigen level becomes negative, less than 5 IU per ml. But when we check with the ELISA, hepatitis HbS antigen is still high and quite reactive, seroreactive. So I would like to have that scenario, your remark on that scenario. Thank you.
This is quite unusual phenomenon. If you say you monitor estrogen level after the therapy and it decrease over time and become undetectable, but when you change to ELISA, you said high titer. ELISA is not the quantification, and it's positive when it's greater than 0.1. And now SNE quantification you can down to 0.05. So if that become negative, I see quite unlikely to have ELISA positive, but they can occur a few things. Certainly, we know that sometimes engine can reverse. This beautiful study from China, they follow up patients, about 1,200 patients, and 1% of that patient has spontaneous S-killer and DNA undetectable, and they follow up over 5 years follow-up, about 1.2% had reversion of S antigen. For myself, when you see S reversion, you have to identify something. Is the patient immunosuppressed? Are they taking any immunosuppression, particularly anti-CD20, and that can have reversion of surface antigen. That's the one thing. Certainly, if they're not immunocompromised and they're doing well and no chemical liver disease and no more enzyme, check whether you have false positive S antigen. It's really so common. You know that heparinized blood cause false positive S antigen in ELISA. And those another group of patients, those who are hematologic patients, if they receive repeated dose of G-CSF injection, they also create false positive S antigen. So you have to separate between false positive and true positive, to particularly in those who remain no more symptomatic, no evidence of liver disease.
Is that long time ago? It's like more than 5 years ago?
Not 5 years ago, just we are treating.
Yeah, and
yes.
is that because of the quantitative S antigen, there are two automatic dilution or manual dilution. In the past, they used the manual dilution, 1 to 400 dilution. Then when you test with ELISA with undiluted serum, that's going to be positive. But sometimes since the dilution is 1 to 400, sometimes negative, but still positive, undiluted.
Currently, and I thought maybe the lab, so I switched to another lab and confirmed still quantitative HbS antigen is negative, but ELISA positive.
ELISA, ELISA sometimes still be positive. If it's not falsely too positive, it can be because partly undiluted blood sample. ELISA remain positive because it's not show you strong positive or weak positive. Usually they can say that more than 250. This one they will say maybe less than, but still positive. My point is you have to look at your patient. If they're positive, DNA undetectable, no ALT elevation, asymptomatic assessment, no significant liver disease, do nothing, just monitoring.
I have to close the session. We're well past a lot of time. Thank you very much, Professor Peter. I'd like to hand over back to the bus officer.
Thank you, CI. Thank you all very much for an informative symposium. I have a few announcements to make. There is a faculty corner on the 4th floor. A variety of Myanmar snacks are available there, and you can also take a rest. Another note only for the international faculty, we have arranged a river cruise for you this evening. So please gather at the 4th floor hotel lobby at 4:45 p.m. Thank you. For our afternoon session, we will begin with UPenn seminar on chronic liver diseases. This session will be chaired by Professor Dr. Jo So-chung and Professor Dr. Uena. May I please invite the chairperson to please take the chair.
Afternoon section will be on hepatitis C and liver transplant. So the speakers are from the prestigious from the University of Pennsylvania, Philadelphia. This is one of the top 10 universities of the world. The first speaker will be Dr. Professor Rajendra Reddy. He's a director of hepatology, medical director of liver transplantation, and director of viral hepatitis. He is a fellow and counselor at large of the American Association for the Study of Liver Disease.